So, may I have your attention, the esteemed faculties and delegates? I would like to take a few moments of your time to introduce myself and the distinguished faculty members of this session. A very good evening and a warm welcome to all the dignitaries present over here today. I am Rituparna from Clarinet, serving as the local session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clarinet serves as the digital partner for this online event hosted by the Cancer Kids Strength of Smiles Doctors Network Maharashtra chapter. And the focus of today's session is multidisciplinary approach to rare chest wall tumors in children. Now, without wasting any further minute, let's begin today's session, for which I would like to invite Dr. Monica Bhagat ma'am, the Honorable Secretary of Cancer Kids Strength of Smiles Doctors Network, Maharashtra chapter, to start the event today with her enlightening words and for the further coordination. So the dice is all yours, ma'am. Please proceed now.
Thank you. I'm trying to share my screen, but
Yes,
I'm
ma'am.
not
Your
able to
screen is
see
shared,
myself.
ma'am.
Okay. So thank you everyone for joining. Thank you, Dr. Shreyasee. I think she is not there, but all the faculty members. So this is our 22nd webinar, and we are talking about multidisciplinary approach to chest wall tumors, which actually sometimes is a difficult task. So we have our experts, Dr. Timothy. He is associate professor in pediatric general surgery in Northwestern Memorial Hospital, Chicago, and thanks a lot for managing the time. We have Dr. Shiva Kumar. He is consultant pediatric hemato-oncologist from vizag. Dr. Shiva, I guess you are there. And then we have Dr. Harshit Bansal. Yes. Dr. Harshit, you are there. He is assistant professor in radiology from Tata Memorial Hospital, Varanasi. And we have Dr. Shreyasee Karmakar. She is consultant radiation oncologist in MGM New Bombay Hospital, Navi Mumbai. I think we'll start with your case first. I'll just stop my share. Will you be doing it? Now, Dr. Navya? Dr. Navya, can you hear my voice?
Hello, yeah, can you hear?
Yes, can you hear my voice, Navya?
Yeah, but I'm unable to see you people. Yes, we can go ahead with the presentation.
Okay, can you see your screen? You're able to see, right?
Yeah, I'm able to see the slides.
Okay, chalega. So please start.
Hi everyone, today I'll be presenting an very interesting chest wall e-wings. My name is Dr. Navyashree. I'm a consultant pediatric hemato-oncologist at Omega Hospitals, Hyderabad. So we had a 10-year-old child who came with complaints of chest pain since 10 months, which is left-sided and aggravates on deep inspiration and decreases with medication. There was no fever, cough or breathlessness. And on examination, there was a pallor, no lymph nodes. Trachea was deviated towards the right and fullness in the left hemithorax and decreased air entry in the left hemithorax and dullness on percussion. And there was no other organomegaly. Next slide, please. So we have got a chest X-ray as the child has come with complaints of difficulty in breathing, and there was we can see a mass on the left side of the chest wall, on covering the left hemithorax. And on CT, we could see there was a large heterogeneous mass which is arising from the lateral part of the seventh rib and occupying most of the left hemithorax. So we have done a biopsy and it was suggestive of Ewing sarcoma, which I don't have the the histopathological slides. And the EWSR1 was positive. And we went ahead and gave 6 cycles of VDC and IE. in view of, and after 6 cycles, we have reevaluated and the disease was stable. So in view of stable disease, we have gone to a second line protocol, second line chemotherapy, which is SOC sarcoma protocol, which includes VIT. And the first cycle he could tolerate, but the second cycle, the next slide, please. So the second cycle, he had a lot of neutropenia and he was unable to tolerate. Next slide. He was unable to tolerate the chemotherapy, so we had to resect the tumor and then go ahead with. I mean, we wanted to the child. They have actually abandoned the therapy and they went back. And later they have again come with similar complaints of breathlessness, and we thought we have done all the evaluation. It is Ewing's, and in view of stable disease and not responding to any of the chemotherapy and radiation, we wanted to give metronomic therapy. Next slide. We wanted to palliate the child and give metronomic therapy with sirolimus, etoposide, and cyclophosphamide. So here my question is, how is there any other way we could have done anything to this child other than the metronomic therapy?
Dr. Shiva, are you there to take this question?
Yes, ma'am.
Okay, so I just 1 second, because we will be completing the session fast. Dr. Navyashri, we actually have this nice presentation in the end, like about the palliative settings. I think we'll complete all the experts discussions first, and then we'll take all the questions.
Sure.
Is that
Yeah,
okay
that
with
should
everyone?
do. Yeah, that should do.
Yeah. Thanks a lot. Thank you. So I'll be sharing my screen, and we'll start with the presentation. Is my screen visible?
No, ma'am.
No, ma'am, not yet.
Okay, sorry. Now?
It's appearing, ma'am. Yes,
Yeah,
now it is visible.
Yeah, thanks. Chest wall tumors, as we know, they are rare tumors, and if a child is having, or even in adults also, if most of these tumors are malignant, they can arise from bony structures and bony or soft tissue structures. Commonest malignant tumors seen in children are Ewing's, rhabdomyosarcomas, and osteosarcomas. So this is what we have. We have skin, subcutaneous tissue on the outside. Then we have muscles and the other skeletal structures, and then we have ribs and spine in the center. So all the tumors, whichever arise, are arising from these tissues, muscles, the nerves, and the soft tissue, what we have here. So we all know that it is a complex skeletal system which ensures the structural integrity, stability for the movement of shoulder and upper arm, protection of the vital structures, and respiratory function. So whenever we are treating these patients, we have to ensure that we're restoring the anatomical defect, we are reducing the skeletal instability, paradoxical respiratory motion is reduced, respiratory failures doesn't happen, and infections are less. So, Dr. Shiva, if you have a child who comes to your OPD with a chest wall lesion, how will you approach that child?
Yes, ma'am. Good evening, all. This is Dr. Shiva Kumar. I'm a pediatric oncologist, done DM from the Tata Memorial Hospital. So, this is a general approach for the chest wall mass, a child with a chest wall mass. So, as you said, it is it may be malignant or benign. So, based on symptoms, clinically also we can, able to we can able to tell some of the differential, benign mostly asymptomatic and except for the mass, and the malignant are a very large tumor, palpable and rapidly growing, and they have associated with the pain, usually malignant tumor present with the pain, and mostly characteristically in the nocturnal pain. Nocturnal pain usually has a characteristic of the malignancy. And as we explained, some of the benign tumors in the chest wall tumors like neurofibromatosis and some vascular tumors, hemangioma and ABC and visible bone cyst, sometimes osteomyelitis, and also developmental varieties of the thoracic cage. And even the malignant tumors, like there are primary and metastatic. Primary or metastatic are more common than the primary in the children. So in the primary, it may be bone or soft tissue, bone like wing sarcoma or, and also skin tumor, chest wall peanut, rhabdomyosarcoma, synovial sarcoma, and also MPNST. Metastatic, it may be neuroblastoma, LCH, leukemia, lymphomas. Next slide. So in general, approach is always starts with the symptoms and signs and symptoms and physical examination with the imaging and biopsy and the staging workup. So carefully see in next slide. So careful history taking, like apart from the onset, duration, progression. In this case, the duration is around 10 months. And usually, history of around less than 3 months, usually we see the malignant. The swelling, yeah, we have to see the swelling, like number of swellings, location of the swelling. It may be anterior thoracic wall, it may be sometimes posterior thoracic wall. And our differential will change with the position of the swelling. And also nocturnal pain, as I said previously, and also the pressure and infiltration by the swelling. So sometimes, as in the case the child present with the respiratory distress in the relapse, I think. So the mass itself causes the compression over the lung, and leading to lung collapse and sometimes malignant pleural effusion. These are the like pathogens is causing the respiratory symptoms, lead to cough, stridor, breathlessness, orthopnea, and also sometimes the posterior thoracic wall mass lesions like Ewing sarcoma, sometimes neuroblastoma, which are extending into the spine, leading to the backache. It may be the vague symptom and significant actually, and also bowel bladder involvement. Sometimes they lead to the infiltration to the bone marrow, leading to anemia and low platelets, critical rash in the history, and also systemic features. We all know like chest wall tumors may be Ewing sarcoma, it may be rhabdomyosarcoma, pleuropulmonary blastoma, or it may be osteogenic sarcoma. So in all these tumors, the systemic features usually associated with the Ewing sarcoma. Fever and weight loss, and it indicates the advanced disease, that is like metastatic tumors. And next slide. So, like in the physical examination, mainly on palpation, you will come to know the consistency, whether it is hard or soft while examination, and also mobile or fixed or tender or non-tender. So, skin over the mass, which is in a surgical point of view, the pediatric surgeon, I mean, most interested on the scare and the biopsy scare, previous biopsy scare. So, the biopsy scare should be noted because it should be included in the surgery. Otherwise, it lead to recurrence. And also, apart from that, regional lymphadenopathy and neurovascular involvement and systemic examination like respiratory, cardiorespiratory, and also neurological examination are most important. Next slide. So this is the like general approach for the chest wall tumor. So after initial stabilization, we need to do some basic imaging to get the local imaging to get the overall picture about the mass, and also for next step is the diagnosis. So we get the tissue biopsy to get a definitive diagnosis, and if required, molecular analysis could be done. And next step is staging. So whether it is whether with bone scan or PET CT, we are going to do the staging workup. Next slide. Dr. Harshal, I think he is having a discussion over the imaging in the chest wall tumor. I'm going to brief regarding this one, I mean, in the approach. So the basic initial investigation is always chest X-ray. We have to do AP lateral view. It may be simple, but gives a very vital findings. Even if it is bony, or it can tell about the origin and detects the cortical distractions. It can detect the cortical distractions, but the limitation is it not allow the comprehensive assessment of the tumor. Next step is the CT scan. So CECT is a preferable, to give the more sensitive detecting the calcified and cortical distractions. It also gives the information about lung parenchyma, details of the extension, and we can plan a biopsy, I mean site of biopsy based on the CT imaging only. MRI is suggested if there is a neurovascular bundle involvement, if any neurovascular bundle involvement. Next slide, please. So tissue diagnosis is the vital in the chest wall tumor. So FNAC, it has a limitation, the amount of histological tissue you get and tissue architecture. So we didn't get the sufficient amount to give a definitive diagnosis from the pathologist. So we have to go for the excisional or core needle biopsy, sometimes incisional biopsy. So excisional biopsy is advised when it is small tumor, less than 3 centimeter, and are in a favorable location, like a lateral chest wall away from the vital structure. Or you can go for a core needle biopsy if the large tumors are located in a critical area. So biopsy is a site. I prefer like biopsy should be done by a surgeon who are going to do the definitive surgery. So as Region mentioned in previous slide. Next slide. So just HPR, so Ewing sarcoma and also RMS and OJS, these are the three important malignant tumors over the chest wall. So I'm discussing briefly. So Ewing sarcoma in a microscopic level, you will see the small round blue cell tumors with the rosette. And so there are many differentials for the small round blue cell tumor. So we do for the IHC. So IHC like CD99 MIG2, which is a diffuse pattern, and also which is more sensitive, and NKX 2.2, which is more specific for the Ewing sarcoma. We can ask for the molecular test only if there is a patchy pattern of CD99, or if it is a negative for NKX 2.2. Otherwise, no need for the Fisher RT-PCR. We are going to get the 1122 reciprocal translocation. Next is RMS. RMS like ERMS, embryonal RMS or alveolar RMS. ERMS is the most common in the chest wall tumors. It show in microscopy, it show the spindle shaped cells with the stromal rich area. And if you alveolar, like as name suggests, the round cells lined up along the spaces resemble the pulmonary alveoli. So they both ERMS and ARMS both differ in the IHC marking. So both are diffuse desmin positive, but they differ. ERMS is more diffuse positive for the myo D1, and the ARMS is diffusely positive for the myogenin. So molecular test is must in case of the RMS tumors. It is a more prognostic factor, especially in ARMS. Next slide. So OJS is the simple, like we need to get the giant cells, and the important thing in the osteoid formation in the biopsy tissue samples. So this is the end for the approach. Up to diagnosis.
Okay, I'll be skipping role of imaging for like just 10 minutes more. Dr. Tim, I'll be asking you this question. Do you have any advice about the biopsies, how it is to be done, what not has to be done? What things are to be avoided when we are doing a biopsy?
No, traditionally we used to do open incisional biopsies for these, but we have moved entirely to doing these with core biopsies. I think the key is just to work closely. For us, we have our interventional radiology colleagues do those biopsies. And I think we used to have issues in the past where we did not have enough tissue for molecular analysis. And as we've sort of refined that, either using the large 14 or 16 gauge vacuum assisted devices, or doing multiple passes, like up to like 15 to 20 passes with a standard 18 gauge core, we get plenty of tissue for both the diagnosis, the immunohistochemistry, and the molecular. And we do that through a coaxial needle so that it is just a single track through the skin and the muscle.
Okay, so whatever that scar is, we have to excise it when we are removing the final tumor. This is to be done.
Remove the biopsy tract?
Okay.
Sorry.
Yeah. So is it always possible to remove the biopsy tract, because the tumor actually comes down when we give chemotherapy? So is it always possible to remove, or we'll have to manipulate or do something with that?
No, I think it's always possible. If you weren't confident that you removed the biopsy tract, I think you would certainly want to also do adjuvant radiation. But I think as long as you mark the location of the biopsy tract, you should be able to remove it.
Okay. So now coming to the local treatment, we have surgical and radiation. Dr. Tim, I think you can share your screen and we can talk about surgery first.
Perfect. You guys can see my slides?
Yes.
Okay, so I'm just going to go through a couple of my intro slides and then we'll get into surgery. So again, in pediatric chest wall tumors, the majority of these are Ewing sarcoma, as we talked about. We talked about some of the other etiologies from non-rhabdo, soft tissue sarcoma, osteosarcoma, rhabdo, and chondrosarcoma. You know, what we found, we did a big review of the data from about 20 US centers, and we found that, you know, about half of these were located in posterior ribs with, you know, kind of split between anterior and middle for the rest of them. And a majority of them were located in ribs 4 through 8, which is helpful because those ones up in the first through third rib are the more challenging ones, which that's only about 23% of them. I'm going to skip through some of these. This is some slides from a SIOP presentation I give. I do want to make the strong point that at least in COG, we strongly discourage initial resection of these tumors because the risk of positive margin when you do an upfront resection is very high. And so with near universal practice, we prefer a biopsy, neoadjuvant chemo, and then an approach to surgery after that. I'm going to skip through this stuff, sorry. And I'm happy to share these slides if anybody's interested in it. So general principles, as we've talked about, is to excise the biopsy tract, excise involved or adherent myofascial layers, but not necessarily full thickness muscle for non-adherent layers. So if there's, you know, latissimus muscle draped over the ribs and it's non-adherent, then you don't necessarily need to remove everything between the skin and the tumor. I think it's very important to enter the chest at a clearly uninvolved interspace, you know, 1 or 2 ribs above or below where you're going in. And I have found that thoracoscopy is a very helpful tool if you're unsure. You can just get in with a scope, you know, far away from the tumor and really plan out, okay, I'm going to get in on this rib, which is just below, 1 rib below where I want to go, or this rib, which is 1 rib above. I think other tools that can be used include you know, intraoperative fluoroscopy. If there's anything adherent, then an en bloc resection is important. So that can apply to diaphragm or lung or other things, including pericardium. For posterior lesions, which can be the more challenging ones, you know, you can do disarticulation without excessive traction to avoid any kind of interspinal hemorrhage. And I will often involve one of my spine surgeons if it's up against the vertebral column. And then, of course, general surgical principles, always label the margin for the pathologist. You know, I think the question that comes up is this adage of 1 rib above and 1 rib below. You know, really the purpose of that is to have a way to ensure that you're getting negative margins. I don't think that, you know, a negative margin resection is a negative margin resection, whether it includes a rib above or a rib below. And so I do think that this is more important for high-grade tumors and for tumors that are not radiosensitive. So some of the non-rhabdo soft tissue sarcomas, for instance, or osteosarcoma, then those are the ones where I always go a rib above and below. But for patients that had a really good chemo response, especially if they're radiosensitive, then it's potentially possible to just take the involved rib plus all of the intercostal muscle above or below. And if necessary, you can add a partial diameter resection of the rib or just the periosteum of those adjacent ribs. And that is often my practice for something like a Ewing's, which is to just take the periosteum of the rib above and below. You don't necessarily need to resect the entire rib. I think it's important to have a several centimeter margin of normal rib along the rib of origin. You know, for Ewing's, there can be this intramedullary extension. And so for those, I tend to try to take the entirety of the rib. But I really use the MRI as a guiding principle for this. And you can get a pretty good idea of the extent of intramedullary extension. The margin is not clear. I try to always get a 1 centimeter margin. Older dogma used to call for even higher or more significant margins, but I don't think there's any good data that this makes a difference. You know, you can do a partial vertebral body resection if necessary to get a margin on the posterior ribs. And, you know, I do recommend collaboration with an experienced spine surgeon for this, but yeah, you can take the transverse process. You can take, you know, part of the vertebral body if that's what's necessary to get that resection. I do want to just talk about some of the outcomes that we have with resection. So in the PSORC study, 41 patients had local recurrence, which is pretty high. This was highest for osteosarcoma. And so osteosarcoma, again, because it's not a radiosensitive tumor, is where we really want to get the best margins. Overall, 5-year local recurrence-free survival was much better for Ewing's and rhabdomyosarcoma, okay? And this is what the recurrence-free survival looked like in time over months with these patients. Across the PSORC study, about 28% of patients, 28% of patients with chest wall tumors died. This was greatest for rhabdomyosarcoma. Even with the local recurrence rates, many of the osteosarcoma patients were still salvageable. And this is what the overall survival looked like in the PSORC study that we did. Again, this multi-institutional US center study. I think it's important to look at some of the other studies. So this was a study from Saltzman et al. That included 76 pediatric and adolescent patients treated at Memorial Sloan Kettering. And this did include a little bit of overlap with our study, by the way. And this went back, several decades. And similar to PSORC, the majority of patients had Ewing's. They also had a bunch of non-rhabdo soft tissue sarcoma. And they resected a median of 3 ribs and had 5-year overall survival of 61%, which was similar to what we noted. And again, as expected, the presence of metastatic disease is the most significant contributor to survival. This is another study from MD Anderson, and this was 44 patients. And this study had a little bit greater percentage of osteosarcoma patients, and predictors of overall survival in their study included histology, with osteosarcoma patients doing the worst, location of the tumor, so posterior location tends to be more unfavorable, and then the presence of surgical margins is a predictor of survival. Monica, did you want me to spend a couple minutes talking about reconstruction techniques or no?
Because you have to leave, I think we'll talk the reconstruction now only.
Okay.
Yeah, you can go ahead, yes.
Okay. So, I think the goals of reconstruction are to restore chest wall rigidity and make sure that you have good respiratory mechanics, so avoid paradoxical motion. You want to protect the thoracic organs. You want to avoid herniation of things like the lung or the heart, avoid scapular herniation into the chest, and allow for subsequent growth. So, in my opinion, the defect size and location are key, and there's no one perfect material or approach. And I think this is kind of the art of surgery, and you have to adapt to the circumstances. Just to give an example, this is scapular herniation, which, you're trying to avoid. So you have options, right? So there's autologous options. And so, flexible autologous options are muscle flaps and myocutaneous flaps, and rigid options are bone grafts. In terms of permanent materials, you have, flexible grafts like PTFE grafts, Marlex grafts, polypropylene grafts. And then you have rigid permanent options like bone cement, methyl methacrylate, or rib spanning systems like the Riblock system, Stratos system, Vector. And then you also have absorbable options. So you have Vicryl meshes or biologic meshes, and you have absorbable plates and struts. And so, with the prosthetic or non-absorbable meshes, the advantages of this is that it conforms to the chest wall. It's widely available, easy to place. It's rigid enough to support pulmonary mechanics. The disadvantages, if it gets infected, it's difficult to clear. It does not offer rigid protection, and it can tether the ribs as the child grows since it's, a fixed size. The keys are to cut it to shape with some overlap of the defect border and secure it pretty taut to avoid paradoxical motion. And this is what these reconstructions look like in action. This was a patient of mine where we did, it was a pretty young child. We did the resection, and we just placed a temporary PTFE graft with the intention to actually, sorry, the pictures on the left are from the a report in the literature. The pictures on the right are my patient. But this is a kid who, as he comes into teenage years, will offer more rigid reconstruction. Muscle or myocutaneous flaps are good options. They're easy to perform. They have a low risk of wound or infectious complications. The disadvantages, there's a lack of rigid protection. And really, you can still get some paradoxical motion potentially with your breathing mechanics. These are good options for small defects under the latissimus muscle or the pectus, where you may not need any formal reconstruction, and you can collaborate with plastics or reconstructive surgery as needed. Here's some example of, doing flaps, either without a mesh reconstruction, or you can do it over a mesh just to provide good tissue coverage. Biologic meshes are widely available. They're great. They conform to the chest wall. They're widely available. They're rigid enough to support pulmonary mechanics. They allow for tissue ingrowth. They're infection resistant. Again, though, they don't offer rigid protection if you're playing contact sports. And they may not be as durable as a synthetic mesh. Similar technical keys as with the permanent meshes, but you want to make sure that, with all meshes, that you have adequate myocutaneous coverage. There are some examples of this in the literature. Again, I'm happy to provide all these slides if people want to see them. Bioabsorbable plates are interesting new development. These meshes come in various degrees of rigidity. And some really can be classified more as almost a bioabsorbable plate if they're more rigid. And these, have pretty small series of reported uses in the literature, but have been pretty successful. I have not personally used these, but I know several people who have, and they've been quite happy with these. Then the question is rigid reconstruction needed? I generally avoid it in skeletally immature children, except for very large defects or where there's concern for scapular herniation. I think for younger kids, methyl methacrylate sandwich, where you just use kind of two meshes with the bone cement in between, is a good option. For older kids, I like the rib spanning systems. And if you have a soft defect, you can just use an orthotic brace instead. This is one of my younger kids who had a 3-rib resection, has a soft mesh in there, and we just provide him, our orthotics folk provide him with a rigid, brace that he uses when he's riding his bike and doing other things. And, he's a kid who will provide rigid reconstruction once he's skeletally mature. Here's what, methyl methacrylate can look like, is really getting that, bone tumor cement in there. And that is another good option for rigid reconstruction. This was a comparison in the literature about outcomes of adult patients reconstructing using rigid and non-rigid techniques. They had about 100 patients in each group, and they used methyl methacrylate for the rigid reconstruction and prosthetic mesh for the non-rigid reconstruction. Both groups had a median of 3 ribs resected, and the rates of respiratory complications were similar between the two groups, but the 90-day rates of overall complications were higher with the rigid reconstruction. So, I would say, if you want to embark upon rigid reconstruction, just understand the risk profile of that. And then for skeletally mature kids, I think rib spanning struts or rib replacements are a great option. It does require you to have fixation points on both ends, but it can be combined with underlying mesh or myocutaneous coverage. So here's some examples. You can also use vector systems. These can be used, you can almost have them running at perpendicular angles. So if you don't have anything to fixate posteriorly, you can run a vector system, along the vertebral column up and down, and then fixate the rib struts to that. So in the PSORC study, 69% of kids had some type of reconstruction. Various reconstruction materials were used. The majority just had synthetic mesh, about 45%. And the most commonly used rigid material was methyl methacrylate in about 23% of patients. So that's it. And then just real fast, I want to comment that late effects, the most important thing to consider is scoliosis risk. In different studies, it runs the range from about 10 to 40%. And if you look at rates that require operative intervention, it's in the 5 to 10% risk. And it's more common if you have posterior resections or with an increasing number of ribs resected. So sorry, that was a quick breeze through some of these topics. Hope that was helpful. And I'll stop sharing.
Thank you. It was really nice presentation. Anyone wants to ask any question?
Yes, ma'am.
Yes.
Dr. Tim,
Yeah.
is it a routine practice for, to do MRI before surgery for the chest wall tumors?
Yeah, I think MRI is, you're saying preoperative MRI?
Yep.
Okay.
Yeah, I think that
When
is,
you are
or did you say intraoperative MRI or just preoperative MRI?
Okay, our surgeon mostly requests like CE, CT, he asks me. MRI rarely asks if it involvement in neurovascular bundle, or if he suspect, otherwise he don't ask. That's why I ask.
Yeah, I think that for, because for this, the extent of the muscular involvement is so important. General principles, I think the CT is very, very helpful for picking up lung nodules and visualizing, the involvement of the bone. But I think for the muscular involvement, the MRI is very important. And especially for Ewing's, I think, seeing the extent of the intramedullary involvement is just much better with MRI. So I always do MRI at the time of diagnosis and at the time of preoperative preparation.
Okay. And what is the cost of this reconstruction?
yeah, those
You
were
told
looking very, very nice. But what would be the cost? Because they were looking actually very nice and expensive.
very, it's look very nice,
Yeah.
but I am asking for MRI. So,
Yeah, for the reconstruction materials, I think probably the most cost-effective rigid option is the methyl methacrylate. That's, the same bone cement that the neurosurgeons use when they have a, defect in the skull after a craniectomy. So that's pretty widely available and cheap. The meshes, I think, run the gamut of prices, but probably the most cost-effective would be a Vicryl mesh with methyl methacrylate if you were looking for rigid reconstruction. The rib replacement systems are very expensive. And so that's why I don't like to use them for younger kids where they're going to outgrow them. And so I only offer that, once they're skeletally mature, if they want something very durable and permanent.
Okay. So, Dr.
thank
Tim,
you.
any more questions?
Yeah, Monica, I want.
Yes, yes, please. Go ahead.
Yeah, Dr. Tim, Dr. Prasanna here. I just want, if there is a vertebral involvement or spinal involvement, how it will be tackled? Which one will be tackled first?
Vertebral and what else? I'm sorry?
The spinal cord or the vertebral involvement is there. Which tumor will be in your, which part will be tackled first?
Yeah, I think anything that's impinging upon the spine needs to be tackled first. I will say, it really depends on the histology. Let's use Ewing's as an example, since that is the most frequent tumor that we see here. If it is truly impinging upon the spine, that is one where I would say we will often do definitive radiotherapy instead of surgical excision. And if there's not an adequate response to radiation, then maybe those are ones who would get a post-radiation resection. But yeah, I think it's important to consider the histology when you're considering that. But for Ewing's and for rhabdo, radiation is really pretty equivalent local control, and so we might do definitive radiation.
Okay. So you have given one contraindication when we should not be operating in radiation use choice. Do you have any other things when we can decide that we don't need to operate this patient? Does it any larger defect or anything? What are the contraindications basically?
Yeah, good question. I don't think size in and of itself is a contraindication. If it's osteosarcoma, within reason, I suppose, right? Like you have to feel like you can get it out. But if it's osteosarcoma, there's not much else you can do besides operate. So you can try to see if it'll shrink with some MAP chemotherapy, but ultimately, unless you think you're going to cause harm that, would be, impair whatever quality of life the child has, if curative intent is the goal, then I think, even if it's I've done like 5 rib resection for osteosarcoma, and I think that is the right thing to do. If it's involving, if it's invading, into the heart, if it's so much diaphragm, involvement that it's down into the liver or the hepatic veins, or, things where the risk of on-table, serious complications and death outweigh the benefits. I think that's where it comes into play. But size in and of itself is not, I don't think, a contraindication.
So we should be sure that we can take it out, then only we should be going in. Otherwise, we'll be in trouble.
Yeah, exactly. I mean, especially, for tumors that are not responsive to radiation, if you don't get the whole thing out, it's not gonna improve survival. And if it's a tumor that is responsive to radiation and you leave gross tumor behind, then they're still getting the same dose of radiation. So they're kind of getting all the downsides of surgery without any benefit. And so for Ewing's and rhabdo, if you do surgery that leaves gross tumor behind, you have probably not done the child any benefit. And so I think, for those tumors that are more responsive to radiation, you really need to look carefully at the imaging and only operate if you think you can get a gross total excision. I think microscopic margins are one thing, but if you're leaving gross tumor behind, then you're probably better off just radiating those children.
Okay. We had a case recently. So basically, if there is a recurrence disease or even in the primary setting, so we have a Ewing's chest wall tumor. So is there any role of doing a scopy and seeing whether there's a pleural disease or where there's a residual lung? So does that thoracoscopy help in planning the thing?
Yeah, I think, thoracoscopy is very helpful for these tumors. I mentioned I like it for planning my incision, but I will also, sometimes use it as a tool to assess resectability. And so I usually will do it at the time that I'm planning resection, but I'll tell the families I'm going to put in a scope and make sure that it looks resectable. Because you're right, if there's, pleural studying, then you're not going to do this child any favor by doing a big chest wall resection. So I do agree that's a very helpful tool.
Okay. So does ICG or any other thing helps you to identify tumor better, or just the vision is okay? I mean, seeing is like very short.
No, I mean, you're getting at a hot topic, and I wish I had more time to stay and talk because
just 1 minute, just one.
Yeah, I think fluorescent surgery with ICG is a very helpful tool for this.
Okay.
For Ewing's and rhabdo for sure. For osteo, it's in my hands been a little bit more variable. There are also new fluorescent agents which are coming onto the market. There's one called pafolacyanine, which targets the folate receptor. That is very, very effective for osteosarcoma. And so I think fluorescent surgery can and will provide more and more benefit in the future.
Okay, great. Just one question for 5 seconds. I want yes or no. What is the time when you give the ICG contrast, they say, the dye? When is it to be given? The right time? Is it like immediately in the surgery or? Yeah.
No, I don't give it right at the time of surgery. So for metastatic disease, I like to give a big dose, like 2 to 3 milligrams per kilogram the day prior to surgery. Although if there are logistical reasons why I just cannot get them in the day prior, then I will give it the morning of, but as much time as possible, because you do want it to clear out of the normal tissue and just remain in the abnormal, tumor tissue. And it's because the tumor has impaired lymphatic drainage that it retains there. So I do think that, kind of 4 to 20 hours prior to surgery is probably your best bet.
Okay. So I won't hold you more. Thanks a lot.
Thank you. So I have to run to the operating room. I have a full day.
Yeah. So thanks a lot. All the best. Yeah. Bye. Thank you.
All right. Thank you, guys.
Thank you.
Thank you.
Dr. Ayush, you're there?
Yeah, yes, ma'am.
Dr. Ayush, yeah, I'm sorry I kept you waiting, but he had to leave. So I'm just sharing
No
my screen.
issues,
We'll
ma'am.
again, yeah. So I have your slides.
Yeah, it's visible now, ma'am.
So for everyone, Dr. Harshit could not join. He had some emergency. So we have Dr. Ayush Mathur. He is in TMH Varanasi with him.
Yeah, ma'am.
Yes, please. Yes, please.
Okay. Good evening, everyone. I'm Dr. Ayush Mathur. I am a diagnostic and an interventional radiologist. I completed my post-graduation from Tata Hospital, Bombay, and currently in Varanasi. I'm audible, right, ma'am?
Yes.
Okay. So, as far as role of imaging is considered for pediatric lesions, chest wall or elsewhere also. Apart from the routine imaging that we have, radiographs and ultrasounds, the most preferred are the cross-sectional imaging, which are the CT and MRI, which can actually give us the composition of the lesion as well, the extent also, and for multiple lesions or metastasis, again, an amazing modality would be there. Then we can have nuclear imaging also, PET-CT, to correlate for the malignant versions and to look for recurrences, for post-radiation changes, and for recurrent and malignant disease, the nuclear studies are preferred. So if I just go one by one through these points to identify the site of origin of lesion, ma'am, you can just we can just see that slide once. I'll go back to the cases again.
The first one, no? The first
The
one, no? This
the
one.
previous one.
Yeah.
Yeah. Thank you, ma'am. So to identify the site of origin of lesion, we can always see for the epicenter of disease and the extension of disease. We can see them as separately. So a chest wall or soft tissue sarcoma going into the bone and a bone lesion involving the surrounding soft structures that we can identify. We can identify the extent of disease if there is an intrathoracic, intraperitoneal, or an extrathoracic extension. The second one being benign and malignant etiology. I'll talk about this point again through the cases also, but they have different internal characteristics, both benign as well as malignant. They will have different kind of borders. So malignant is supposed to be infiltrative, so it will have irregular or ill-defined border. And as far as inner composition is considered, the benign tumors or benign lesions with more of homogeneous appearance, rather as malignant lesions should have necrosis also. They might have hemorrhages within them, as well as dystrophic calcifications are quite common. For characterization of lesion, of course, apt to say what is it solid, is it cystic, are there hemorrhages within or not, and then figuring out a differential diagnosis for that. To look for extent, the extent, is it intrathoracic, extrathoracic, intrapleural, extrapleural, and of course, most importantly, intraspinal extension, which actually uh, changes the course of action of the lesion also. So if it's just eroding the vertebral column, is it within the pre or the paravertebral space, or is it actually indenting upon the spinal cord or infiltrating it? So all of these questions can be answered very readily through actually MRI, as it has a better soft tissue contrast. To know the local extent and decide on the operability, whatever the criteria are there for the operable and non-operable lesions. Metastatic workup, again, cross-sectional CT as well as nuclear imagings are uh, amazing to decide. I will just go for the case one. If you can just back one slide, ma'am. Okay. So I have just a couple of examples to go by it. So if you can see these reconstructed contrast CT images in both soft tissue as well as bone algorithm images are available over here. So we can see a wide, mostly well-defined heterogeneous mass. Heterogeneous why? Because there are internal some areas of necrosis also, and we can see it is associated with lytic erosion of the left posterior rib, as well as we can confirm it in the coronal sections as well as in the reconstructed bone algorithm images. So there is a permeative lytic type of erosion uh, in the left posterior rib associated with a periosseous soft tissue. And if we can see, it is just pushing the abdominal viscera ahead, the spleen ahead, without infiltrating it, as well as we can see there is posteriorly there is involvement of the paravertebral muscles also, not reaching up to the subcutaneous tissue. So all these like answers can be provided by cross-sectional imaging along with their sagittal and coronal reconstruction. Also, we have a nuclear imaging to go by it, which can actually tell us about the avid or the metabolically active area. So what is the importance of these areas? I would just say for a radiologist or an interventional radiologist. So picking up the site of biopsy becomes very important. So in large lesions, seldom we can see there are internal areas of cystic or necrotic change, which can give you a poor yield of core needle biopsy. So having a nuclear imaging pre-biopsy or pre-intervention helps us decide what areas to target. And again, so that is one in de novo cases. Secondly, for recurrent cases or in post-radiation changes, or to differentiate it from infective pathologies also, nuclear imaging gives us an idea of what areas should we target, and then we can go ahead and target them and get a better yield of biopsy. also for pediatric patients, we do not want to repeat our biopsy again if we get a negative for one side, because again, we might require anesthesia for it, need to be done under general anesthesia, unlike adult procedures or adult biopsy, where we can readily do with them under local anesthesia. So that is why we want to be sure that we are targeting the right areas. Ma'am, we can go on the other side, please. The next slide, please, ma'am. Yeah. So this turned out to be a Ewing sarcoma. So we can, ma'am, one slide back, please. Just the previous slide. So thank you. So the last one was a diagnosed case of Ewing sarcoma. We were targeted the well-avid lesion from the PET CT, and then we response images also after the treatment. In the next slide, ma'am. Just the next slide, please. Thank you. So as these are highly radio and chemosensitive tumors, in the follow-up imaging, we saw that there was a significant reduction in the size of the tumor, and we can also increase the operability of those as well. In the second case, this was a 13-year-old male patient. Again, a very large lesion in the left lateral thoracic wall, also going into the axilla, insinuating between the left lateral rib and the scapula. So in this, we can actually see it is not eroding the bones as such, it is insinuating in between the soft tissues over there. And then we have a nuclear imaging also to go by, which actually tells us most of it is solid, most of it is the tumor component, and most of it is avid. So again, we can target the avid regions and we can come to a better biopsy yield we can get. Then we can visualize there is no intrathoracic extension. It is generally a well encapsulated lesion. We can go to the next slide, please, ma'am. The next slide, ma'am. Fine. So these were the different planar MRI images in which we can see again well capsulated lesion. I'm just back, please. That's it. Thank you. So we can see most of it is T2 heterogeneously hyperintense. We can see those black areas, which are actually the flow voids, which actually interpret the vascularity of the lesion. And then we have axial as well as the coronal post-contrast images, which we can see their intense enhancement within the lesion. So it is a solid lesion. And then we have diffusion images to actually see again the active component. It is showing good restricted diffusion as well. So all the images, MRI especially gives us better soft tissue extent of the lesion, the muscular involvement, and on the contrary, CT gives us a better bony detail. So Ewing sarcoma for periosteal reaction, bony involvement, rib extension, CT gives us a better idea. On the other hand, muscular involvement, the neuromuscular bundle, the intraspinal extension, and spinal cord edema can be better given by MRI. So this was a biopsy-proven case of low-grade spindle cell neoplasm, and IR-guided preoperative embolization also was done because we can see there it was highly vascular, intensely enhancing, multiple vascular collaterals going into it. So it devascularizes the lesion so that the operative blood loss can be reduced, as well as the size can be reduced so that the operative planes become better. I have just one last case to go by it. Ma'am, next slide, please. Thank you. So again, we can see in this 8-year-old child with a painless swelling over right shoulder, also the neck and the right axilla, since 6 years. So 6 years gives us an indolent course of the lesion, gradually progressive. So more in favor of a benign pathology or a benign aggressive pathology. So if we can see, these are the CT images. We can see on the mass is localized on the right lateral chest wall, the axilla, as well as on the right lateral part of the neck, also in the coronal image. So if we can see the density of the areas within the lesion, we can see there are the black areas, which are actually fat density. So we can always rely on the Hounsfield units of the internal lesion. So -10, -20 HU values gives us something somewhere around fat. And other areas, which are the intermediate areas, are the solid component areas. So the fatty areas gives us the lipid component or the fatty component of the lesion. We can see this is not an infiltrative lesion. It is well demarcated. It is just pushing on the viscera, the muscles besides it, as well as the vessels, but it is not infiltrating it. So that, and as well as 6 years history gives us an example of a chronic benign disease kind of a thing, or a chronic benign or recently aggressive. So this came out to be a liposarcoma. So again, just to summarize, CT gives us better bony or a bone or a cortical details or bony expansion, great enough for chest wall lesions, Ewing sarcoma. And MRI gives us a better detail of the soft tissue involvement. It can be nerves, it can be muscles. And then we have nuclear imaging to proceed with biopsy to recurrence in post-CTRT cases, good to localize. So these are the imaging modalities we can use. And of course, the imaging modalities for pediatric patients would always be just an initial radiograph or ultrasound to go by, as they're readily available. Do not require any anesthesia, but should definitely be done by the cross-sectional imaging. I think I'll just finish over this, ma'am. Thank you, ma'am.
Hello?
Hello. Yes, ma'am. I think
Sorry.
yeah.
Okay, I just had a call. So, so the one thing, the scans you have, this scan especially for this patient, if we have to see brachial plexus, because I think this is that location now. So, is there any specific scan we have to order?
For this particular case, ma'am.
Yeah, because I think brachial plexus ka hi area hai na, so it can be involved. So, is it possible to see brachial plexus you want to see in this scan?
Yes, ma'am. So in this scan, we can actually trace them by using the axillary vessels as a landmark, because CT is a good for the vessels. But as far as involvement is considered, we should and we cannot comment upon CT, but we have dedicated MRI sequences for brachial plexus. So we should always go by them to see the nerve involvement per se. As far as CT is considered, if we have only these scans, we can use the axial vessel as a landmark to just see, and the pectoralis minor to see if it is questionable involvement or not. But definitely should be MRI, ma'am.
Okay, great. Thank you. So we'll meet Dr. Shreyasee, are you there?
Hello, am
Dr.
I
Shreyasee? Yes, you're audible. So local treatment would involve surgery and radiation. So we'll have Dr. Shreyasee to talk about the radiation now. I am just...
Yeah, I'll just share my slides.
Yes. Dr. Shreyasee, you're able to see?
Hello, is my slides visible? Are my slides visible?
No, ma'am, not yet.
Okay. Just a sec, huh? Give me a sec.
Sure.
I'll try to find till the time you had shared it with me also.
Okay, you can also share. I think I had sent you. Not an issue.
Yes, I will. Yes. Okay, so I'm sharing your slides.
Okay, yeah, fine. Yeah. Hello, everyone. I'm Dr. Shreyasee. I have done my MD Radiation Oncology from Tata Memorial Hospital, Mumbai. So today we will be discussing the multidisciplinary approach towards the chest wall tumors. Especially, I'll be emphasizing on the Ewing sarcoma. So as we can see, majority of the this slide only, yeah. So majority of the tumors are mainly seen in the pelvis and ribs. The lesions in the Ewing sarcoma and ribs are usually seen in 10 to 12% of the patients. Next slide, please. So Ewing sarcoma is best managed in a multidisciplinary way. It has to be multimodality management. We have to give induction chemotherapy followed by local treatment, which may be the surgery or radiation, followed by maintenance chemo. So duration of each is approximately around 9 weeks for 9 weeks and around 29 weeks. So induction chemotherapy is definitely suggested at the beginning because around 25% of the patients are metastatic at presentation and 1/3 of the patients have micrometastasis, so they may relapse in future. Next slide, please. So I will skip what is the workup and all as per the NCCN guidelines. Next slide. So coming to the local therapy, even our NCCN endorses radiation and chemotherapy as the primary treatment. What about the post-op patients? So if after excision, if there is margin positive, then radiation is recommended. Even if for margin negative, radiation is recommended in certain cases, and I will be telling what are the indications for post-op radiation as well. So even after primary treatment, if there is a relapse of the disease, radiation and chemotherapy is also suggested, and it is suggested by the same thing is with progressive disease. If there is a progression of the disease following primary treatment, radiation has to be considered and either as a primary or in the relapse setting. Next slide, please. So what about the metastatic Ewing sarcoma? In case of metastasis, for achieving local control therapy to the primary site, so radiation and chemotherapy again is an option. And same is with the metastatic if it is widely metastasis, and palliative radiation is given in such cases. What about the metastasis if it is in the lung? In case of oligometastatic disease, radiation is an option. And if there is a partial or complete response, then whole lung irradiation is considered. Next slide, please. Yeah. So what exactly is the role of radiation in Ewing? So achieving local control is very important. It is of the utmost importance in Ewing sarcoma because the long-term survivorship also decreases if the local relapse is there, and it becomes less than 25% if there is a local relapse. As such, there is no head-on comparison or no RCT comparing the surgical and non-surgical approaches. However, there are some biases in selecting the patients for radiation, and the outcomes of several studies have shown that the surgical outcomes are much better compared to the radiation. Next slide, please. So what exactly are the indications of radiation? So radiation can be given in definitive setting as a post-operative radiation or even in pre-operative setting. So in case of definitive setting, where all do we suggest radiation? So we usually suggest radiation if it is an unresectable or inoperable tumor, or in the site is not favorable for surgery, like in spine, as Dr. Tim had already told, if the lesion is a spinal lesion, or if it is in the base of skull or chest wall. So these are the certain anatomical sites where radiation is definitely preferred. If we consider that the surgery is quite morbid or there is some unacceptable outcomes like orthopedic outcomes or functional outcomes post surgery, then radiation is the option. Even if there is a poor response post chemotherapy, then radiation is considered as a local treatment. When all do we consider post-op radiation? So if there is a grossly or microscopically positive surgical margin, or the incision or the resection is either intralesional or there is a marginal resection of the tumor, then post-operative radiation is recommended. If there is a poor histological response, that is the necrosis post-chemotherapy is less, then radiation is advised. Now coming to the how much should be the necrosis for post-operative radiation. So there is no consensus guidelines as such. Usually, it depends upon the institutional practices. Some consider around 90% of necrosis, while some recommend even 90 to 99% necrosis is there, then radiation is recommended. If there is a contamination of the plane before surgery, or if the local disease at presentation is a large disease, more than 8 centimeter, then radiation post-surgery is recommended. Preoperative radiation, mainly we consider if the lesions are very large, or there is a slow response to chemotherapy, or the lesions are very marginally resectable, then we usually give preoperative radiation so as to shrink it and make it operable. Next slide, please. So post-operative radiation. So when to give, how much to give, and how to give. So indications I have already told regarding post-operative radiation. Coming to the timing, when should we consider post-operative radiation? It should be usually within 6 to 8 weeks following surgery. What should be the fractionation? We usually prefer conventional fractionation, that is 1.8 to 2 gray per fraction. And initially, we give around 45 to 50 gray dose of the radiation. And if there is some gross or microscopic disease remaining, we usually give additional boost dose to that area only. Next slide, please. So this is basically our prescription, what we prefer for the radiation in post-operative settings, as well as the primary and preoperative settings. So it usually ranges between 45 to 50 gray, and additional boost dose is given in case of R1 or R2 resections. Next slide, please. So does post-op radiation really benefit if there is if there is a poor response post-chemotherapy? So it has been seen that even if there is a poor response post-chemotherapy, local failures decrease almost by half if we give them post-op radiation. So in a study, it was seen that if there was 5%, the local failures have reduced to 5% from 12% post-radiation. Next slide, please. So nowadays, there's a lot of hype between whether radiation should be given by proton or therapy or photon therapy. So proton therapy definitely has advantage, especially in pediatric patients, because mainly the main advantage is that the proton therapy does not have an exit dose. So the exposure is less. As such, the long-term side effects in pediatric patients which is very important, is quite less compared to photons. So there has been few studies which have shown that there is not much difference between the outcomes with whether you treat with proton therapy or photon therapy. However, the toxicities and the long-term and acute side effects are quite lesser compared to the conventional photon therapy. Next slide, please. So before coming to the case scenario, I have not added the slide, but I would just like to share what about the side effects of radiation. So one of the concerns in post-op radiation is that what about the flap failures? So there is MGCH data which has shown that most of the cases, like around 95% of the patients, have viable flap even post-radiation. And the flap viability may also be an issue even without radiation in certain anatomical sites like distal femur or proximal tibia, So flap failure should not much be of concern with radiation, and especially with advanced radiation that we have now, like IMRT and volumetric arc therapy or VMAT. The toxicities which we see are very, very less. So these things should not be a concern as of now. Regarding second malignancy, yes, it is known that second malignancy occurs in pediatric patients. However, the percentage is very less. It is around 2 to 10%. And most of the, even if it occurs, then it is salvageable with surgery. And once again, usually this data are from the older days where the conventional radiation techniques were used. But now with improved techniques and modern advanced techniques, we don't see much of a side effect. So long-term toxicities also decrease, as well as malignancy also decreases. So coming to our case scenario, our patient was a 14-year-old boy. He had presented with right hip pain and swelling for 3 months. I'm not going into the details of the initial diagnosis. He was diagnosed as non-metastatic Ewing sarcoma of right pelvis. He was started on EFT 2001 protocol. He received definitive radiation to pelvis to a dose of 55.8 grain 31 fraction with intensity modulated radiation till August of 2019. He then completed his maintenance chemotherapy till January 2020 and he was on follow-up and he was clinico-radiologically controlled during that time. He developed orthopnea and chest pain in September 2024 after a DFI of 4 years, 9 months. PET-CT was done and it showed a consolidatory mass in the left lower lung. There was moderate pleural effusion, which was considered as malignant. There was a 4 mm right lung nodule, which again was considered metastatic. And there was an intramammary node, left IMN, which was metastatic. He was started on EFT salvage protocol. And post 4 cycles of salvage chemo, there was a partial response. Surgical opinion was sought, and it was told that due to the large residual disease involving large extent of pleura, there would have been uncertain benefit with extensive surgery, and it was advised that the patient should continue with salvage chemotherapy. He received 5 cycles of chemo, and then he underwent PET's left lung lower lobe metastectomy in January 2025, and HPR showed sarcoma. So currently we are treating this patient. So in phase 1, we have planned for treating the whole lung, that is the whole lung irradiation, along with the left pleura because there was disease disseminated in the left pleura and the left IMN. So this is the phase 1 where we are giving a low dose radiation, and further to the left internal mammary chain, we are giving a higher dose till 24 fractions. Next slide, please. So this is how, if you see, the first image shows how one beam is focused towards the lung. The blue part that you are seeing, that is the lung, and the reddish part you can see, that is the heart that had been delineated. So how in one beam there are multiple beamlets and the intensity of each beamlet is modulated. So this is how a intensity modulated radiation works. So there were several beams, multiple beams directed towards this. And the third image shows how beautifully only the lung is receiving the desired dose with multiple beams and beamlets. Next slide, please. So this is the axial and coronal section of the same, and it is showing the 95% distribution of dose in both the lungs while sparing the heart. Next slide, please. This is the phase 2 that we are treating, and the first image is how only the internal mammary chain is receiving the dose, and the second one is the entire chain showing the dose distribution. Thank you. Hello. Hello.
Can you hear my voice?
Yes, yes.
So any questions from anyone? Okay. So this case presentation has already been done. Just one question,
Hello.
Dr. Shreyasee.
Yes.
Yeah.
Hi, Dr.
Yes.
Shreyasee.
Hello. Yeah, hi.
Yeah, can I speak?
Yes, yes.
Yes, yes, please.
Yeah, hi, this is Dr. Manish here, Dr. Shreyasee.
Yes.
Yeah, so you have given 43.4 dose to the IMN chains, and the whole lung bath was 12.7 gray at 1 gray
12.6
per
gray in
fraction.
yeah. So the
7 fraction,
entire
that's one.
whole lung with left pleura and the internal mammary chain, we had given 12.6 and 7 fractions, followed by only the irradiation to the IMN chain because there was a gross disease. Yeah.
Okay, so what was the total volume received by V5 volume of the both the lungs?
So I don't remember that, but then it was 95% coverage of 12.6 gray. So, but I can, yeah, because
Okay,
that is
so
what we are treating. Yeah.
Okay, and pre-treatment, did we do any PFT volumes about the patient?
PFT was not done, and this is not recommended also for whole lung irradiation, because we are not expecting any side effect or toxicities with such lower dose.
Okay, but the
So
patient
it's
had
not.
undergone lobectomy as well as
Yeah,
he is
vas
undergoing
lobectomy before that. Before vas lobectomy that was done, but however, I don't have
Correct.
the PFT findings with me now. But then before radiation, we did not do because it is not done on a regular basis. Also,
No, correct. But before lobectomy, we had undergone PFT.
Yes.
Correct.
He had done.
Okay.
Yeah.
And we are doing a follow-up every 3 monthly for the patient as of now, or
He
6
is still
monthly?
under treatment. He is still under treatment.
Achha.
Yeah,
Oh,
he's
sorry.
receiving treatment currently. Yeah, but then
Oh,
still
sorry.
it's 3 monthly till 2 years is what we follow.
Okay, fine. Chalega. Thank you so much.
Yeah. Okay.
Dr. Shreyasee.
Yes, Dr. Shiva.
Yeah, so I mean, in case of pleural effusion without any lung nodule, so what is the
Okay.
role of radiotherapy in that?
So if it is malignant and we are suspecting disease, we may give whole lung irradiation, but then only to the pleural disease we are not considering. If it is indicated, then we can consider whole lung irradiation.
Okay, I mean pleural effusion. So
If
we
it is
give
malignant.
malignant
First we will
only.
say with first we will give chemotherapy only. Even after that,
Okay.
if it is residual, then we can consider. But then first we will have to consider chemotherapy.
So Dr. Shiva, when you are doing when you recommend biopsy to your patients, so there's a fluid, so the child is a effusion also. So biopsy के साथ में do you also recommend to do a effusion, the tap, to know whether it is malignant or reactive?
No, ma'am. No need to do.
Okay, so the fluid, how will we get to know whether that effusion is reactive or malignant? Because I think radiation will be planned on that. Yeah, the radiation will be planned on
it
that.
must be
So
malignant only. We don't do
oh, it is
only.
malignant. So
It
we
is
don't. So
malignant
we
only.
consider. So we consider a chest wall tumor with a fusion is a malignant effusion, and we have to radiate, right? So there's no chance of it being a reactive thing.
Yes, ma'am. Only, I mean, pleural effusion without lung nodule is rare. So
Okay.
in many cases, we do whole lung irradiation only.
Okay.
And
So it is whole lung only.
But because it is a matter unless proven.
Okay. So Dr. Shreyasee, can you
Hello. Hello.
Hello.
Yeah. I can hear you now.
Yeah. So there's one. So you said that if the tumor is not chemosensitive, we can try radiation. So what I understand is if the tumor is chemosensitive, it is supposed to be radiation sensitive also. But if it is not chemosensitive, the radiation won't work. Is it true?
No, I did not tell that. So first we will go ahead with chemo only.
Yeah.
But even after chemo, if there is partial response, then we can consider radiation. Just like in this case we had considered. So whole lung irradiation we can consider that.
Okay, so for aggressive tumors and with the tumors which are not very aggressive, is there any difference of difference in the dose of radiation, or it is just that a low benign tumor will not get any radiation even if the margins are positive? Is there any histology that way?
So yeah, the dose will differ depending upon the histology also. Like for Ewing's, it is different, while for soft tissue sarcomas, those are more aggressive, and the doses for that are also higher.
Okay.
And for benign, definitely we don't give.
Okay. So the rib reconstruction and other things that Dr. Tim was talking about, do they interfere in radiation? Does it affect the radiation part?
So the post-op bed we do give. However, if it is only thing is it should not throw artifacts what the implant has been used. But however, it does not affect as such the radiation delivery or the planning.
Okay.
It won't differ
Great.
much. Yeah.
Okay. So coming back to our presentation, Dr. Shiva, question for you. If the child presents in emergency with respiratory symptoms, how will you manage the child?
Yes, ma'am. So imagine like a child with a chest wall mass with a respiratory distress. So like I mean, this respiratory distress, like even mild or severe, ma'am. So depends on that. We need to manage. Any patient with a respiratory distress should be taken to emergency ward or in ICU setting. We need to manage. So we need to keep the child in initial stabilization. We need to keep the child in upright position with a vital monitoring and initial SpO2 and respiratory and pulse rate monitoring. And with we need to supplement with the O2 by mask or nasal prongs. Usually, I have seen many patients. So usually with the O2 by mask by nasal prongs, the respiratory stress will decrease to some extent. So after that, we need to order for a portable X-ray. So we need to we should not send the patient to a busy X-ray room. So the child may collapse with the respiratory distress. So we need to do a portable chest X-ray if possible, like both in API and lateral. Otherwise, in RPA, PAV or APV, everything is fine. So we with the X-ray, so I already explained with the minimal X-ray only, we come to know many things like. In a chest wall mass, the main pathology for respiratory distress is it may be because of the massive pleural effusion, or it may be the mass itself causing the compression over the lung. So, and the thoracic wall is, the expansion of the thoracic wall is also limited. So, because of this, the child is having the respiratory distress. So, with the X-ray, we come to know whether it is a massive pleural effusion and mediastinal shift and the mass extent also. So if in that case, we need to do diagnosis with a minimal, at least attempt a least invasive means of diagnosis. So we don't know the mass, whether it is a hematolymphoid or it may be some solid malignancy. So we need to do all the investigations keeping in the mind. So it is like a clinical situation. We need to decide on the invasive, least invasive things like CVC with MDC. Even you do tumor markers, or you do the pleural tapping. It may be therapeutic or diagnostic. And the peripheral lymph node samples or CT scans. Next, we can check the CT scan. We can send for the CT scan, and we can based on the imaging only, as a Dr. Harshit told that based on the imaging only, we can come to some conclusion like provisional diagnosis. If we get a provisional diagnosis, we give the appropriate therapy. Or if, even after the least invasive diagnostic test also, if you are unable to get the diagnosis, then we proceed with the empirical therapy. So emergency VAC is the term used for the chemotherapy. Like if you don't know the diagnosis and the child is having only mass is causing the respiratory distress. So in this setting, we give the VAC chemotherapy, vincristine 1.5 mg per meter square, and doxorubicin 60 mg per meter square, and cyclophosphamide 600 mg per meter square. So, the chemotherapy, this is the chemotherapy used in an emergency situation because it is a very short acting. The myelosuppression is a very short duration, so we are not much worried for the neutropenia. Neutropenia, cytopenias, and febrile neutropenias. Usually, we get after chemotherapy. And also this is like having the alkylating agents and also anthracycline agents, which are usually used in the solid malignancy. So that's why this is the chemotherapy used for the in emergency setting with the respiratory distress, because the respiratory distress will not decrease. The child will not get stabilized other than chemotherapy in the setting of the chest wall mass. If we will, after giving chemotherapy, we will wait for around 24 to 48 hours to see the response. Reassessment. If the child is responded, that is okay. If not responded, we can ask the radiotherapist to give the pala-RT. 4 to 6 gyre of RT can be given to to get the symptomatic relief. Otherwise, mostly VAC chemotherapy will give the sufficient, around 48 hours, the child will get some relief. Even if there is no relief, if the child get relief, we can proceed with the biopsy, and with caution, we can get the definitive diagnosis. even after chemotherapy, even after radiotherapy, also the child not having any symptom relief, then we'll go to the pediatric surgeon. I mean, go for the surgical resection. So this will be the approach, ma'am, for the chest wall mass with the respiratory distress in the oncology setting. I mean.
So if chemotherapy and radiation is not helping, surgeons will come to rescue.
Yes,
Seems
no,
like.
final option is resection only.
But considering that it is going to be a big mass causing all those things, I think surgery will also be difficult. But anyways, we have to evaluate. So
Mostly
coming
chemotherapy
to
will
next
first.
thing, so yeah,
Okay, ma'am,
chemotherapy
proceed.
and radiotherapy, and then yeah. So there are situations in evenings when we don't treat them or we tell them that the outcomes are very bad. So even in the recurrent settings also. So would you please tell us about those situations where we don't offer much of the treatment? Dr. Shiva?
Yes, ma'am. Yes, ma'am. So,
Yeah.
so this is like a primary metastatic Ewing sarcoma. So I will explain this once. I mean, so metastatic, it may be pulmonary or bone marrow. So pulmonary mets or pleural mets, the number of metastatic lesions in the lung doesn't matter for the Ewing sarcoma. But it is like in osteogenic sarcoma OGS. So like more than 3 are non-resectable lung nodules. So we straight away go for the palliation. But in Ewing sarcoma, because we give whole-lung irradiation, which increases the EFS by 20%. So we are considering the multiple metastatic lesions in the lung is a curative intent. For when coming to bone or bone marrow only mets, one bone met, the 3-year EFS is around 47%. The more than that, the EFS is decreased to 30%. If bone marrow met, it is around 23%. So when considering like whether any patient for palliation curative intent, so the EFS minimum should be around 50%. So if anything less than 50%, we are going to palliate, except neuroblastoma, metastatic neuroblastoma, where the EFS is at 25%. Still, we are going for the curative intent, but Ewing sarcoma is different. So yeah, and if both lung and bone marrow mets, the EFS 3-year EFS is 12% only. So the palliative settings in the primary metastatic Ewing sarcoma is like more than one bone met and bone marrow metastasis, and if involving the both lung and bone met. So these are the palliative settings. Next slide. In recurrent Ewing sarcoma, so the treatment options, ma'am, as I mean, in the previous case, as explained, so they used as sirolimus and other metronomic chemotherapy. So in recurrent Ewing sarcoma, the overall prognosis is 30% only. The most important prognostic factor is time of relapse. So early relapse and late relapse. So I mean, for clinical research purpose, they use the 2 years is a cutoff for the to define the early relapse. But in our institute, we use 1 year. So less than 1 year, local relapse or metastatic relapse, it is a palliative only. We don't treat because the outcome is less than 10%. So only if because we unable to give the radiation, which is the important. I mean, for the local control, even also metastatic control. So we can't give the radiation. So the less than 1 year, we are straight away go for the palliation. If it is like more than 1 year, so we attempt treatment. If it is a local disease, and also metastatic if only lung. Otherwise, if it is a metastatic disseminated recurrent Ewing sarcoma, we go for the palliation only because the outcome is very less. So I mean, this is for RMS, ma'am. Should I explain now?
Yeah, just about, you can take time to explain this slide.
Yes, ma'am. Ma'am, in primary metastatic RMS also the same thing only. I mean, there is a paper which is a famous one. I mean, study Oberlin paper. It is a large study around 788 patients. So a 3-year EFS is 30%, OS is 35% in a metastatic RMS. In this study, the risk factors like after univariate analysis with the prognostic risk factors are histology, age, site, bone and bone marrow, and number of mets. So if any patient having the more than one more than one side metastatic, the EFS will fall to 15%, 3-year EFS. If it is a one side metastasis, the EFS is 45%. So any metastatic RMS patient, more than one site metastasis, going to be palliative.
Okay.
Yes, ma'am.
So I think outcomes after resection has already been discussed. Dr. Shreyasee, would you like to talk about the complications post radiation? I think you have covered those
Yeah, I
also.
have more or less covered, but if anyone has
Yes,
any question, I can, yeah, I'm happy to answer. I'll be happy to answer.
Is Dr. Navya there? Okay. So any questions from anyone? Now we are open to discussion.
I have
Okay.
a question.
Okay.
That radiotherapy, after the lung irradiation, how do you follow up for that whatever fibrosis or changes in the lung, especially when the both lungs have been irradiated?
Yeah,
What's the protocol?
so for the whole lung irradiation, see the dose for that is quite less. So for fibrosis and pneumonitis, with that dose is not expected much. So we don't do any particular follow-up for that. But however, as the patient is already on follow-up for the primary disease, we are anyways doing a chest X-ray and this CT scan or the PET scan. So that is the regular follow-up. For specifically for whole lung irradiation, we are not doing any follow-up, and that is not warranted also.
Okay, fine.
Dr. Saurabh, I think your question is answered about the follow-up schedule. Okay.
I have a question. What is the role of OMCT, Dr. Shiva? What is the role of OMCT in this Ewing sarcoma setting? Any role?
So after completion of chemotherapy, I mean primary,
Both
no role
primary
only.
and in salvage setting. So you are
In
giving as
salvage
of
setting.
now?
No, we are not.
Routinely
Following.
you are practicing? No.
No, we are not giving any OMCT after 33 weeks of chemotherapy. There is a end of treatment only. We follow up
No,
with
if there's a relapse.
If there's a relapse, yeah, we give after completion of the therapy.
Salvage
After
chemo.
salvage chemo.
So after salvage chemo, you are giving OMCT?
OMCT, yeah.
Oh, okay.
I have Dr. Shiva, can I ask a question?
Yes.
What is the role of genetics in this chest wall tumors? How important is is this going to change the management? Any chemotherapy management will be changed?
Role of genetics, like sarcoma, as per if less than 2 years kid with the sarcoma, like Ewing sarcoma. So in that case only we will do like P53 and all. So otherwise, routinely we don't do.
No, not recommended.
Not recommended.
Hello. Am I audible?
Yes, ma'am.
Yeah. So I can see Dr. Shilpa ma'am and Dr. Faiza. Would you just share your experience about chest wall reconstructions?
Very nice cases presented. Thank you.
Yeah. Any comments from surgeons? Okay. So we'll just close the session. If possible, can you please switch on your cameras? I'll just take a snapshot. Thank you everyone for joining. But I want more cameras on. Yes. Yeah, I have taken. Thanks a lot. Thank you, everyone. Thank you.
Thank you.
Thanks.
Thank you. It was a nice session. Thank you.
Thank you. Thank you, Ritu. Thank you, all the experts. Yeah.
Also, thank you everyone. Thank you for sharing such valuable insights and extending us the opportunity to host the session. So I hope you had a seamless experience. Now, with all your permission, as there are no further questions, we are signing off for today and looking forward to host you again soon. Thank you, Monica ma'am, once again.
Thank you. Thank you,
Goodbye.
Ritu.
See you. Thank you.